Thank you very much for this invitation, and appreciate being able to join you for a little bit here. So I'm going to be speaking about what the role of robotics in hernia surgery is. I'm trying to move my slide, and it is not working from the clicker. Oh, there we go. Here are my disclosures, and I will be speaking about robotics, and two of those companies make robots. My overviews, I'm going to be talking about inguinal hernias and then move on to ventral hernias as well. So with inguinal hernias, let's talk about whether the robotic repair is worth it. So we can look at it from a few different aspects. So yes, it's got good safety profile and outcomes. No, it's too expensive without any benefit. Absolutely, what a great teaching tool, and maybe in certain circumstances. So let's start with the yes. So we've had numerous studies published which show the positive outcomes, the safety aspects of using the robot for inguinal hernia surgery. If we look at one large population study, which is relatively early in the whole utilization of robotics, we see that there was this is from New York State, we see that there was a higher recurrence rate compared with open surgery, however, compared to laparoscopic surgery rather, about the same as open surgery. However, if you look a little bit more carefully, it was a selected population that underwent robotic repair. So a higher risk population with higher BMI comorbidities in the robotic group. And the overall incidence of recurrence they felt might have been due to some confounders. And again, this was early on, so a large number of laparoscopic repairs, a small number of robotic repairs. So the no group really comes from the belief that there's no benefit. And so one randomized controlled study, which came from the Cleveland Clinic, you can see here that it was a lot of different sites, and they found no clinical benefit. A few things important to notice about this study. 6 sites, 13 authors, 3 years. That's a long time to accrue 100 patients for inguinal hernia repair. They said that the experience was 25 previous robotic cases, but you still wonder if this was perhaps a little early in their overall experience, especially since they found that the rate of frustration for the surgeon was higher with the robotic surgery. And then it wasn't the same operation either in both groups. The laparoscopic group had a tacked mesh with a peritoneum that was tacked closed, and the robotic group had a suture repair with the mesh being sutured and the peritoneum being sutured as well. They did publish a 1 to 2 year follow-up of the study and found no difference in terms of their two groups in terms of recurrence, wound morbidity, pain, and physical activity and quality of life. So then let's move on to the no, it takes too long answer to robotic repair for groin hernias. So almost every study and systematic reviews have shown that there's increased time for the robotic groups. However, if you move from unilateral to bilateral repairs, this time big difference becomes a lot less and may potentially not even exist at all. And then, of course, you follow this with the expense of it. A longer time period, of course, is going to be more expensive. This chart here doesn't actually include inguinal hernias, but I think it's a good one to be able to see how much across the board with different procedures that the cost is higher when you compare with just minimally invasive surgery with a laparoscope. When we try to look a little bit more carefully in terms of where the increased cost is, of course, it's not surprising that the personnel cost with a longer operative time, as well as when you look at the device itself. This is even in the hands of a surgeon who has a high amount of experience, that you can see that the costs remain higher. So then the absolutely group. So I think that it's important to focus on the adoption of MIS techniques. Laparoscopic inguinal hernia repair has been around for many years now. However, data from several different places shows that it's a relatively low adoption of the rates. So this is a study that came from Canada, which shows under 20% in one province. And this is from the state of Michigan in the United States, and also shows, other than some little hot spots, some very low overall adoption of MIS techniques for use in inguinal hernias. In U.S. academics, the use of robotic technology has increased significantly over the years. And you can see with this bar graph showing the adoption of different techniques that the red, which is the inguinal hernia, has increased significantly over the last decade or so, even through the pandemic years. And so this really, I think, comes to the crux of things where you can see that laparoscopic actually stays about the same. So it's really the open group which has adopted the MIS techniques of using robotics. So it hasn't decreased laparoscopy. It's just increased overall use of MIS techniques for inguinal hernia repair. And we see worldwide procedure trends as well here. A systematic review that was published last year shows pretty much the same thing that we've seen in the other studies that I've shown so far, is that compared with laparoscopy and open surgery, complication rate is about the same, that operative time is definitely higher, and they noticed some decrease in hernia recurrence, though that has not necessarily been shown in a lot of studies on their own. So what about in certain circumstances? This is where I fall in, is this is my algorithm in terms of approach of the patient with the unilateral inguinal hernia. And for me, when I'm planning on doing something as a TAP in my hands, that is with the use of robotic arms. And when it's a bilateral inguinal hernia, you can see that the indications for my algorithm increase a little bit more. And importantly, I'm a TAP surgeon. So doing TAP, there's always some reasons for it. So I'm going to be watching 4 different videos here where I think that there's utility to robotics. The one that started already is a big scrotal hernia. You definitely have a lot of advantages from being able to have an intra-abdominal view, and especially with these big fatty hernia sacs that are sometimes a little complicated to figure out what is sac, what are the contents that are going in there. And then we'll get the other ones going. In the right lower quadrant, we've got previous extraperitoneal mesh and a recurrence. In the left lower quadrant, we've got an appendix that's in the hernia, as well as we're going to have to go look at the other side where we've had a preperitoneal repair. The top left quadrant, that's a femoral hernia, and that's definitely very nice to do this way where you have those vessels really close by and you have such great visualization. Scrotal hernia there, you can see up top right that we get the advantage of looking from below, trying to see if that sac is still going up, especially as the anatomy just gets a little bit tricky with all that fat there. In the right lower, you can see that we're removing the mesh that was in place from the previous extraperitoneal repair, and removal of that mesh, and you can see a lot of shrinkage that's happened, will allow us to move ahead and place a nice smooth flat piece of mesh. In the left lower side, we're taking down adhesions in the left groin because the patient had some left groin pain after previous hernia repair. And we've taken it down. We don't see any obvious hernia. So then we're going to go and get started with our dissection on the right side, get into that extraperitoneal space, come down to the midline, and then be able to go look in the left groin. And that really allowed us to be able to get to the space of the previous mesh and to make sure that there wasn't any recurrent hernia in that area. I think importance with all of these MIS techniques, whether laparoscopically as a TAP or as a TAP with use of robotic arms, key thing is to make sure that that myopectoneal orifice is well dissected. You can see in the left lower quadrant there's that mesh from the previous one. Just really checking to make sure that there isn't any type of a femoral hernia there, which is what an ultrasound had questioned before. Oops, I guess I've lost my connection as they warned me with my clicker. Okay, great. So we're moving on to ventral hernias now. So let's start with IPOM, however you would like to pronounce it. So this is back in 2000 when all these series came out with the utilization and of intraperitoneal onlay mesh, and they're large case series. I think it's so that was the year 2000. We're now in 2025. In that time period, we've had a lot of things change in the world. These are all things that did not exist in the year 2000. So of course I got this using ChatGPT, and I did it a while ago. So this is ChatGPT 3.5. Now that we have a new ChatGPT, so ChatGPT 5, I asked it to generate a word cloud for me. And it told me these are all the things that we did not have back then. So definitely we've also adapted our technique. And so IPOM went from just plain IPOM to the plus version of it, where we had fascial defect closure. And the adoption rates of the IPOM ventral hernia were actually quite significant, even in the early days, where we saw an increase by 40%, because it was easy to teach and there wasn't any difficulty in terms of identifying anatomy. And so then we kind of move on and say maybe we overused it. So for a patient like this, got an IPOM, that was the final effect, which I would say is a failure, even though this patient was happy. And we also see that worldwide, that we started seeing a decrease in the overall utilization of lap IPOM, and that's the red line that you can see there. And at the same time, we started seeing an increase in the open sublay. And you can see a tiny little increase in component separation, which is the yellow line, but not that much quite here. And that was from the Hernia Med Registry. So the question comes down to is how dangerous is intraperitoneal mesh? So this is a study from Palala where it was following up a large series of patients who had an IPOM plus split pair. And when they visited the abdomen for any other reason. And so you can see that close to 90% of their patients had no adhesions or had minor adhesions. Of course, this is with one specific type of mesh, but regardless, I think that it gives us some data that otherwise we didn't have. Meta-analysis of intra versus extraperitoneal mesh also identifies no difference in terms of overall rates of complications. And then we have one case series which followed a bunch of patients. The video that I'm showing you there is a mesh construct that was placed open, but essentially acts like an IPOM mesh, except for the fact that you can see that one edge was not well fixed to the abdominal wall. This was a view 2 weeks post-op. I was in there for a mesenteric venous thrombosis, which required some bowel resection, but you can tell that that mesh does not look the way we'd like it to look. So the Cleveland Clinic followed up 325 of their patients who had IPOMs before, and they noticed one early small bowel obstruction. Otherwise, we're able to follow up these patients for 3 to 6 years. And their overall rate of reoperation is under 1%. So is IPOM inferior to other techniques? We're starting to get more and more data comparing it with other techniques. So again, Cleveland Clinic has really been great in terms of doing randomized studies and great other science. And so they had a randomized controlled trial of IPOM versus ECAP. They found no differences between the two groups. And strangely enough, at their 1-year quality of life study, they found that the IPOM group had a higher quality of life. I don't know that there's any really good explanation for that as of yet. And this is looking at a systematic review of IPOM plus versus ETAP as well. And so not surprisingly, longer operative time for ETAP and less pain, also not surprisingly, at post-op at day 1 and at about a week after. No differences in any of their other outcome measures, though. So what about TAP? So TAP is easier to learn, shorter than ETAP, longer than IPOM, and otherwise you can see the rest of it here. It is going to be a little bit less expensive than IPOM, mostly because of the type of mesh that can be used in that location. And then retrorectus, of course, I think this is not surprising that if you have a large enough hernia that you require retrorectus, that you have some better outcomes when you do retrorectus compared with lap-IPOM. But the main thing that they've noticed was in terms of readmission rates as well as length of stay over 2 days, which was shorter for the retrorectus group. Of course, I've told you that IPOM's not bad, but then we all have cases like this where we're taking out mesh, and also when we're in there operating for other reasons, and the intraperitoneal mesh just does not look the way that you wish it looked when it went in. And then we have the mesh litigation side of it. This is in the United States right now. We have all these multi-district litigations, and you can see the huge number is just absolutely mind-blowing. We're not special. The UK also has mesh compensation. Most of what I found in the UK, however, seems to pertain to the vaginal mesh. However, that's how it started in the US as well. And then it just kind of jumped up to all types of mesh, essentially. So I think there's an overall interest in terms of how to get mesh out of the abdominal cavity. And this is where the robotic technology has allowed us to do operations that otherwise were very difficult with just the straight sticks. And so what about robotic IPOM though? You'd be like, why would you even do that? Well, again, we do have a study that looked at this, and it's definitely ergonomically nicer, especially for taking down some adhesions, closing the defect, and it's definitely not ergonomically nicer in terms of putting the mesh in and suturing it in place. Tacking it is much easier. And when they did this study, they really didn't notice that much difference, other than they had a higher reoperation in the laparoscopic group. And then otherwise, like, really nothing significant in terms of their other outcome measures. So how do we train people to get proficient in these techniques and to safe surgeries? So we've got online videos and then training modules, simulated training. Then we start, especially with our residents, bedside assistants, consult, and then ongoing mentoring. So let's just look at a midline incisional hernia here. And we're just going to look through a little bit of a video of doing a robotic tap, which is my go-to for people with kind of medium-sized hernias. And I think this one shows some of the difficulties as well as the advantages to using this. Number one, for I think a small to medium-sized hernia, you have to think twice before you decide to violate the retrorectus space. And especially in people like the CT scan, you probably noticed before, this gentleman is a little fluffy. It doesn't have morbid obesity, but I feel like in those folks, there's definitely some advantages to getting a moderately large piece of mesh, and then ideally mesh outside of the abdominal cavity. So here we've taken down the adhesions. Unlike when you're doing an IPOM or other operations, you want to try to leave the peritoneum intact. And so if anything, sometimes if it's just fat, we'll take those adhesions by erring on the side of the fat as opposed to on the side of the peritoneum. As we're slowly creating this preperitoneal space, we're getting to one of the hernia defects. You don't have to take the sac down. However, if you see just to the right of where we're taking the sac down, we've created a hole in the peritoneum. So we know that we're going to have to do something about closure of that or patching it up in some fashion if we're going to move ahead with placing an extraperitoneal mesh. So in those scenarios, if the sac comes down nicely, I'm going to take it because that is going to help me after. Frequently, even if you can't do that, doing a large dissection allows you to recruit a lot of additional peritoneum, which will allow you to close up any holes that you've made during the dissection. In this operation, fat is your friend. So you always want to head up towards the falciform and get in that space because that's going to be easy. As you get further lateral, the peritoneum gets less thick and it gets less sturdy. Now we've dissected everything down. We have almost as scary eyes for Halloween there in terms of two defects. Measure, see how large a mesh we're going to be placing in there. And then we're going to go ahead with closure of the defect. If there is a diastasis involved there, which kind of fits into the dissection plane that we've done and is symptomatic, I will incorporate that into my closure by plicating the diastasis and then moving on ahead to the closure of this. So our midline is closed here. So then I sometimes use a self-gripping mesh, sometimes use just a flat piece of polypropylene in this area, and then center it on the closed defect. And then once we do that, I still place some sutures even if I use the self-gripping mesh, just at the corners. I don't know, just makes me feel better, even though it's unlikely that this is going to move anywhere. And then if we find that it doesn't fit correctly, you just make that space a little bit larger. And which is not usually very difficult. And there you can see the sutures that we're placing in the corner. So after the mesh is well situated and we're happy with how that looks, then of course the last part of this operation is closing up that peritoneum so that so that the mesh is well situated outside of the abdominal cavity. So here you can see already that it looks like we've got a lot of peritoneum, and that's what happens once you've created a large dissection plane. You just end up recruiting a lot of peritoneum. And then once this is closed, you can see there's some holes there. So we have to plan on how we're going to take care of these holes. And so there's that hernia sac. I'm just going to pop that up there. You can take a stitch almost anywhere. And then just bring it up to your suture line, and that'll help close up holes. And then we just make sure there aren't any other holes. And the smaller ones, often you can just put a simple stitch on. So then, last part I want to talk about a little bit is ergonomics. So how is the ergonomics of the robot? You'll initially hear people say, "I love it." Data is not that great. This is a study looking at one of the open console robots and doing these rapid body assessments with photographs. And they did find that the ergonomics appeared to be better with this specific robot. A survey that was done from the SAGES ergonomics group said that most surgeons said that they were following best ergonomic practices, but a lot of them still have pain. And of course, women, equipment is never actually good for us. So the higher risk of pain there. But you'll hear a lot of robotic surgeons talk about how they feel that this has increased their operative lifespan by 5 years or so because of the ergonomics. Well, I don't know that I want to operate for another 5 years. What I want to do is be able to spend the time in my garden. And having moved to Southern California a few years ago, I do 12 months out of the year. And that I want my hands for that. Not clear cut if the robot's actually going to protect my hands. Because if anything, I would say that I feel less strain on my back and my neck, maybe more in the small muscles of my hands. So but a lot of people do feel that this is better for their health. And we probably will see more studies that suggest that there is an ergonomic benefit. And so then you've got this the institution's telling you that it's very expensive, we have to talk about how much is the health of a surgeon worth. So it costs a lot to educate a surgeon. This is from the United States. This is from the UK. And then also an interesting study that I ran into is looking at, in addition to that, all of the kind of hidden costs of medical school and moving onwards from there. And so it's really finding the balance between the additional cost of the technology and talking about how much we invest into creating doctors and surgeons and how much we need to invest in keeping them healthy. So robotics for hernia repair is safe. It's more expensive in the US. It's more costly in the UK. It's definitely moving the needle from open to MIS. We didn't get into retromuscular and PAR, but as there's definitely a benefit there for the more complex hernias, and we may see ergonomic benefits for the surgeon. I think with any new technology, there's often a lot of concerns about it. And these are quotes about, futureless technology, circus surgery, risks for the patient. These were all statements made about laparoscopic cholecystectomy in 1986. The German surgeon was essentially vilified for that. And then the first time that it was actually presented at a meeting was by Jacques Maritain in 1989 at the SAGES meeting. And you can see the drums in the background there. He was able to present it in the exhibit hall. It didn't even make it onto the scientific program. We've definitely come a long way from there, and I think it's very interesting that these were comments made by Maritain many years ago. And when you have a visionary, it's definitely a visionary well past this time. And he foresaw a lot of what we are still doing. Thank you very much.